My name is Stuart Gold. I am a consultant anaesthetist at the Royal Derby Hospital. This podcast outlines the results of a project we undertook on behalf of the NHS National Technology Adoption Centre. 3 hospitals took part in this implementation project: the Royal Derby, Manchester Royal Infirmary, led by Dan Conway, and the Whittington in London, led by Martin Cooper. There is a huge drive for increasing the quality of care, improving outcomes for patients, and reducing operating costs in the NHS. This includes using innovative products and technologies to make a dramatic change to the current treatment methods. Oesophageal Doppler monitoring was designed to allow clinicians working in theatre and intensive care units to assess the effects of fluid administration on patients. Planned care clinical leaders in the East Midlands have agreed to the use of the Oesophageal Doppler monitor as a form of goal-directed fluid management as part of the rollout of enhanced recovery after surgery. We will be scoping potential usage across all of our major acute hospitals and working with clinical teams and commissioners to support take-up. Approximately 2 million major operations are performed per year in the UK. Reducing length of hospital stay by 1 day in this group would release a large amount of resource. Reducing length of stay by improving quality of care, in this case using an innovative monitor, has the effect of increasing productivity and will also prevent hospital-acquired infection and reduce thromboembolic disease. Reducing length of stay fits perfectly with the QUIP initiative. Henrik Kellett first introduced the concept of enhanced recovery in Copenhagen in the 1990s. This involves a multifaceted, multi-professional approach to patients' perioperative care undergoing major surgery. The results of this type of care package can be extremely impressive. In Copenhagen, they managed to reduce their length of stay following open colorectal resection to 3 days, although this was associated with a 20% readmission rate, which we would probably consider to be unacceptable. The Department of Health has launched the Enhanced Recovery Partnership Programme to improve the quality of elective care pathways, which should lead to reduced length of hospital stays. Clearly, in the current financial climate, this is a high priority for individual trusts as well. I genuinely believe that the only way that length of stay can be reduced without increasing readmissions is by improving every aspect of the patient's care. Most patients are well aware that the risk of hospital-acquired infections and venous thromboembolic disease are related to the length of time you spend in hospital. As you can see from this slide, anaesthetists should have a central role in this process of setting up and delivering an enhanced recovery pathway. The Oesophageal Doppler project looked at just one aspect of enhanced recovery, which was optimizing fluid management. The Oesophageal Doppler monitor is a minimally invasive device which is placed into the esophagus of the patient once they have been anaesthetized. The probe is focused on the descending aorta and a typical waveform is displayed on the monitor. Fluid is given in boluses and the effect of this on stroke volume is recorded. Fluid boluses are given until there is no further increase in stroke volume and the patient's cardiovascular system is considered to be optimally fluid loaded. Training is provided by Deltex, the manufacturer. This normally takes the form of a short classroom-based session for a large group, followed by individual training in the workplace with accredited trainers. The graphs shown demonstrate the limitation of traditional cardiovascular monitoring during surgery. Often patients are given fluid based on their heart rate and blood pressure, but as you can see on the right-hand side, systolic blood pressure and heart rate do not alter significantly following removal of 25% of total blood volume from volunteers. Human physiology is extremely well evolved to cope with significant blood loss. The autonomic nervous system effectively switches off gut function and blood flow. This makes sense in a fight or flight situation. You aren't going to stop for something to eat if you're being chased by an animal which may kill you. Unfortunately, when this happens during major surgery, the gut suffers from reduced blood flow, which is particularly worrying if you're having part of your bowel removed and stitched back together again. The graphs on the left-hand side show the effect on gut pH, which becomes more acidic while the heart rate and blood pressure are unchanged. The effect of this reduction in gut blood flow has consequences ranging from delayed return of gut function to life-threatening anastomotic breakdown and the need for reoperation. Oesophageal Doppler monitoring has been researched in a number of randomized controlled trials, but despite this, use of the monitors is patchy. Lord Darcy highlighted this apparent anomaly in his 2007 report, A Framework for Action. 3 years on, little has changed. Here is a summary of the published randomized controlled trials demonstrating the advantages of esophageal Doppler monitoring. Alternative cardiac output monitors are available, but most are based on arterial waveform analysis and are therefore more invasive, and none has been shown to affect clinical outcomes. Our project was designed to evaluate the effect of widespread introduction of this monitoring technique in patients having major surgery. The 3 sites were specifically chosen for their varied size, geographical location, surgical procedures performed, and case mix. This was an implementation project and not a randomized controlled trial. These have already been done and demonstrate that there is an improvement in patients' outcomes if esophageal Doppler monitoring is used. This project was an example of translational research. Local Research Ethics Committee approval was not required, as this is an accepted standard of care already in use in many hospitals in the UK. Each site did have approval from their local audit committees to ensure data protection issues were adequately addressed. No patients were randomised to receive this type of monitoring. We set out to demonstrate whether widespread introduction of ODM fluid management would yield the same impressive results in outcome in a real clinical setting and in a large patient group of 1,300 patients. We also wanted to find out what stopped clinicians from using this well-proven technique. One of the strengths of our project is the large number of patients being studied. Our project has data from 1,300 patients. The combined sum of the randomized controlled trials used in the meta-analysis totals only 915 patients. Our project was an uncontrolled, real-life clinical assessment. It seems that all research being implemented into clinical practice should undergo a similar validation to show that results can be replicated in a real clinical setting without the biases associated with extra clinical staff involved in clinical trials. This should provide a realistic context to demonstrate the utility of esophageal Doppler monitoring. This is likely to gain maximal improvement in patients' outcomes when combined with a comprehensive enhanced recovery pathway. The results from our 1,300 patients, with approximately 650 patients in each group, show a highly significant reduction in length of hospital stay, reducing by 3.6 days. The case-matched historical control group had a 17.2 day length of stay compared to 13.6 days for the esophageal Doppler project group. This result is highly statistically significant. Traditionally, these results should be presented using non-parametric statistical methods such as median and ranges. However, from a health economic perspective, means represents the actual number of beds used by this patient group. These length of stays may seem fairly high, but there were a wide range of major surgical procedures performed: colorectal cancer, fractured neck of femur, renal and pancreatic transplants, renal and pancreatic cancer surgery. Here are the results from the Royal Derby Hospital. For practical reasons, the project in Derby was undertaken in exclusively patients undergoing colorectal surgery. This group has an expectedly lower length of stay compared to the total project group. The Derby group still has a statistically significant reduction in length of stay of 2.5 days, from 11.9 in the historical control group to 9.4 days. A significant additional benefit of using esophageal Doppler monitoring is a reduction in use of central venous catheters for invasive monitoring. Central venous catheters are an invasive monitor with a significant number of early and late complications, ranging from pneumothorax, carotid artery puncture, and catheter-related sepsis. The whole project group saw a reduction in central venous catheter insertion rate from 44% down to 34%. This 23% reduction is highly clinically and statistically significant. In the Derby group, there was an even greater reduction from 44% to 26%. This 41% reduction is also highly clinically and statistically significant. Whilst our project has demonstrated reductions in length of hospital stay and central venous catheter insertion rates, it was important to ensure that we were not causing any adverse effects using the esophageal Doppler monitor. Despite reducing length of hospital stay, there was also a reduction in readmission rate from 3% to 2%. Whilst this did not reach statistical significance, it does demonstrate that reducing length of stay was not at the expense of increasing readmissions. Remember that Kellett's original work reduced length of stay dramatically to 3 days for colorectal resection, but this was associated with a 20% readmission rate. There were no reported adverse effects from using esophageal Doppler monitoring. Specifically, we were looking for local trauma, heart failure, and esophageal trauma. Using esophageal Doppler monitoring provides better blood flow to the gut during and after major surgery, and we hoped that this would reduce the rate of anastomotic breakdown and need for reoperations. There was a reduction in reoperation rate from 8 to 6.2%, although this was not statistically significant. The potential benefits of widespread esophageal Doppler use are impressive. Most patients are now aware of the potential risks of being in hospital, from deep venous thrombosis and pulmonary embolus to hospital-acquired infections. Reducing length of stay and reducing insertion rates of central venous catheters will have a positive impact on all of these potential complications. Crucially, this has come without an increase in readmissions or reoperations. In fact, these events were actually reduced, although this did not reach statistical significance. If ODM is widely used nationally, then the potential cost savings are enormous, but it must be stressed that to discharge patients sooner without increasing complications means that a much better quality of care is being provided. To summarise, using esophageal Doppler monitoring appears to be a safe, minimally invasive intervention which in isolation can reduce length of hospital stay by at least 2.5 days in patients having major surgery. At the same time, use of more invasive monitoring, namely central venous catheters, is reduced by at least 23%. This intervention appears to be associated with a reduction in readmissions and reoperations, although these are not statistically significant. I believe that incorporating esophageal Doppler-guided fluid optimization will yield the best results when combined with a comprehensive enhanced recovery pathway for major surgery. Full project results are available on the NTAC website. Thank you.